Very well. Let's get underway. I'm Paul Dazan, and I want to welcome you to our monthly ACLP webinar. We had a wonderful series this year with case conferences and literature review presentations. We have a wonderful annual meeting, but we want to extend the community of CL. Hope you'll join us next year, where we hope we will have a equally strong program. We're delighted to present Mark Oldham today with a repeat of an event we had last year, a review of the most important studies in delirium. Mark is an assistant professor of psychiatry at the University of Rochester. Rumor has it he'll be associate professor of psychiatry effective December 1st. You heard that here for the first time. His background includes training in our fellowship. He has served the Academy in a number of roles, including chair of the Proactive Psychiatry SIG and deputy editor of our journal. Finally, he's the president-elect of the American Delirium Society, so he's got strong credentials to present today's talks. If you have questions, please put them in the Q&A box, and we'll try and cover those at the end. Go ahead, Mark.
Well, thank you so much for the introduction, and thank you to everyone who's joining us today. As you heard, we'll be covering 3 of the most impactful studies on delirium in the past academic year. So first off, for disclosures, I have no conflicts of interest to report. I am funded by a K-23 from the NIA, and also we have an Innovation Project Award from the American Heart Association. And I have a lot to cover because these are 3 really robust studies. So in the interest of full disclosure, I may talk quickly, just so you know. Let's see, the first study that we're going to cover is called the SAGES study. This is the 6-year cognitive trajectory of older adults following major surgery and delirium. This is a study conducted by Sharon Inouye and her team at Harvard. And honestly, I think after you see this, you will see why it is so impressive, the amount of work that went into conducting this study. So again, I've said it's the SAGES study, successful aging after elective surgery. Previously, the 3-year outcomes of SAGES were published in 2016. And in this follow-up study, they just continued the follow-up period with each of the subjects. They were evaluating post-op delirium and its association with the degree of cognitive decline in older adults up to 6 years after surgery. So this is an observational cohort study enrolling adults 70 or older having a major elective surgery at either Beth Israel Deaconess or the Brigham with an anticipated stay of 3 days or more. The exclusion criteria are fairly standard, but I will note that their definition of dementia for exclusion is very rigorous, including a history of diagnosis, an assessment at the time of screening, and then also based on performance in the full neuropsychological battery. And then you see other exclusions here. So I mentioned the neuropsychological battery. The components of the battery are listed here in this figure on the right. They did the neuropsychological battery at 12 time points. And you'll see that battery probably takes about 45 minutes or so to complete. And with over 500 subjects, you just imagine the logistics here. The neuropsychological battery assessments were blinded to study, the assessors were blinded to study hypotheses and delirium status. And they took all of the results of that battery to create a single composite score that they've called the general cognitive performance. It was normed to have a mean of 50 and a standard deviation of 10. They also enrolled, in addition to the surgical cohort that you're going to hear about, a non-surgical sample of over 100 subjects, simply so that they could account for retest effects using this battery and kind of understand clinical trajectory over time. So the assessments for delirium were equally rigorous. They were done daily until discharged by trained research personnel. The assessment included the long form CAM, the MDAS, the delirium symptom interview. The assessments were enriched by chart review, and also where family and nurses were available, they were interviewed as well. And you'll see here the kappa for inter-rater reliability was excellent. And so here's table one. First thing to point out with this arrow, 24% of subjects in this study developed delirium. The average age was about 75. It was roughly 50-50 males and females here in the study. Education, this is a very educated group, on average 15 years of education. And then here at the bottom, it says about a quarter of them had some impairment in instrumental activities of daily living. And the final thing here, this is a predominantly orthopedic surgery population. So 4 in 5 here having an orthopedic surgery. And this is kind of the take-home figure. And this is really the entirety of all of those assessments kind of coming together in this figure. So first off, I'll point out on the bottom left, the covariates that were included were pretty robust in terms of what they were adjusting for. And then to orient us here to the two figures at the top, the y-axis is shown from about 45 to 60. So obviously this is just kind of a snapshot of performance. And I said it was normed for a population average of 50. So this was a higher than average performing cohort. Those who had delirium started out lower than those who did not develop delirium. But when you take off the offset and you map them onto one another, those who had delirium had a 40% greater decline over the 6 years than those who didn't. I'm not going to cover in detail the sensitivity analyses. That's a whole separate appendix or supplement that reviews them. But suffice it to say that even looking at different forms of accounting for missingness or non-normality, in general, one would expect at least a 30% decline, even on sensitivity analyses. But the aggregate of the data would suggest about a 40% greater decline over 6 years. So from this study, we can say a couple of strengths. First off, this study covered 2,600 plus person years of data, which is genuinely impressive. They enrolled a separate non-surgical cohort so they could adjust for retest effects using the neuropsychological battery. All of the assessments were very robust, and they had similar retention rates in both groups. A few limitations. Number one, as I've mentioned, this is a highly educated, predominantly white sample. They did not assess amyloid status, which could have contributed, and they did not control for post-op events or medications. Again, this is an observational study looking at delirium as the primary predictor, and they only used a single baseline neuropsychological assessment to adjust subsequent trajectory. So what's the conclusion? Delirium was associated with a 40% greater cognitive decline 6 years after surgery. For context, that's about the same degree of decline as having at least one ApoE epsilon 4 allele. And I think what we can say from this is, although we don't quite know, what the cause of this is, this doesn't tell us cause, at the very least, we know very robustly that delirium indexes future cognitive decline. And another thing that I'll add, it's unclear just from this study alone, again, this is a postoperative delirium model, unclear whether the trajectory would be specific to post-op delirium or delirium occurring in other settings, other contexts, other causes, and so forth. All right, study number 2, the haloperidol for treatment of delirium in ICU patients. I think for us in CL psychiatry, perhaps one of the more important studies to consider. So the study is known as the AID-ICU trial. For some background, in 2005, a retrospective study was published that found haloperidol to be associated with lower mortality among mechanically ventilated ICU patients. Again, kind of a striking thing, haloperidol saving lives. And then subsequently to that, but obviously after this study began, there was a post hoc analysis of the prospective reduced delirium prevention trial, which suggested a dose-dependent improvement in survival with haloperidol. And so this study is a prospective randomized trial to see, does haloperidol save lives? And specifically as well, help people get out of the ICU and out of the hospital faster. So it's really a composite outcome of survival and days out of the hospital. So this was a multi-site study across Europe. This enrolled adult ICU patients with delirium, and here the contraindications to haloperidol being an exclusion as we would expect, also outpatient or current antipsychotic, and other exclusions as we see. So this is a randomized trial. Notably, for that second bullet here, they stratified the different blocks and assignment, not only based on trial site, but also delirium motor type. So hyperactive versus hyper versus hypoactive delirium. The two trial arms included on the one side, IV haloperidol, 2.5 milligrams 3 times a day. So about a roughly 50% bioavailability. So basically double that if you're talking about an oral dose, and indistinguishable placebo on the other arm. The agent was given from randomization to discharge or death in ICU. As needed doses of the study agent were administered up to 20 milligrams per day of haloperidol, or 4 milliliters per day of placebo. Rescue agents were allowed of propofol, benzos, and alpha-2 agonists per clinician discretion. And then the study agent was paused if both delirium assessments were negative on the same day. So there's one thing I want to highlight on this enrollment chart, and that is that they reviewed or assessed 1,700 patients for eligibility, but they enrolled 1,000. That's actually, in my mind, pretty impressive. That means over half of the people they approached for recruitment ultimately were enrolled. So I think that really speaks perhaps to the generalizability of this study. And here we're going to cover table 1 in 2 separate slides, kind of broken up. So first off, the median age was 70 in both groups, roughly. Females comprised about 1/3 of the entire sample. And then here, just to highlight for they accounted for risk factors for delirium in both of the arms. And suffice it to say that they were well distributed and roughly equivalent in both of the arms. Second part of table 1, you see that about 2/3 of the subjects in the study were in a medical ICU. About 1/3 were in the SICU. About 2/3 of the cohort were mechanically ventilated. And then again, for our purposes, and a question that always comes up, about 45% of the subjects had hyperactive delirium. So roughly equivalent, 1-to-1, equal parts hypo and hyperactive in this study. Table 2 here shows the use of haloperidol or placebo. I'm sorry, apologize. Shows rescue medication and open label antipsychotic agents. I'm just highlighting here under rescue medications that both groups received nearly identical, kind of proportion of each groups received each of these rescue medications. And then looking at the use of open label antipsychotic agents, about 13% in each of the arms received that. And it's interesting because it doesn't look like haloperidol, the haloperidol arm, is actually preventing people from receiving a lot of these rescue medications or open label antipsychotic agents. So again, kind of an interesting piece of data here. So this is the primary outcome. As I mentioned, it's a composite outcome, days alive and out of the hospital at 90 days. So when you look at the primary outcome, basically no difference, insignificant statistically, but there is this curious finding that is statistically significant looking at overall survival in those who received haloperidol. We're going to come back to that in just a moment. But I'll highlight before we do that the serious adverse reactions, and as I mentioned earlier, the use of rescue medications, really no different in the two arms, two notable secondary outcomes. But this is the survival curve between those who received haloperidol and those who received placebo. And I mean, if you didn't know any better, it looks like whatever the one group received in the kind of orangish line, that helped survival. And that was the group that received haloperidol. Again, kind of a striking finding. And to kind of drill into this a little bit more, the study authors had already done a pre-planned, I should say they pre-planned to do a secondary Bayesian analysis of their data. So Bayesian analysis, a little different from frequentist statistics in that you take a pretest probability, you have some likelihood ratio, and then you have post-test probability. If you're interested, this is a nice kind of tutorial on Bayesian statistics with some good examples in kind of perisurgical data, perisurgical settings. But in any event, I'm just going to show two graphs here. So this here is the all-cause mortality at 90 days. And on the right, you have absolute risk reduction or absolute difference. These vertical highlighted blue or violet bars represent effect sizes that were kind of predefined as minimally clinically important difference of 1 day in either direction. And the sigmoidal curve represents the kind of cumulative, kind of aggregate, kind of percentile, if you will, of where it would be. And the likelihood that haloperidol improved survival is in this graph about 95%. So again, kind of a striking finding on this analysis as well. And then, did haloperidol hurt anyone or cause serious adverse reactions? Again, this kind of violet or blue shaded area being the kind of predefined minimally clinically important difference of 2 percentage points in either direction. And you see that this curve fits almost entirely underneath, suggesting that the probability that haloperidol led to more likely led to a serious adverse reaction was about, I don't know, 2%, 3%. So again, the likelihood that it hurt anyone in the sample is actually extremely low. So a couple of strengths and limitations of the study. So this is a double-blind, placebo-controlled RCT. This was multi-site trial with a large sample size and broadly generalizable results, as we saw more than half of the people they assessed, they recruited and enrolled. Notably, the kind of the criterion for enrollment, kind of a positive delirium screen, was based on clinical staff identification of a positive delirium screen. So it's not, that was not being done by a research personnel. Delirium duration was not a study outcome. Again, this is really about saving lives and getting people out of the hospital more efficiently. And the analysis was not adjusted for sedatives, analgesics, or non-pharm interventions. So what can we conclude from the study? So on the kind of the a priori composite outcome, haloperidol did not lead to a greater number of days alive and out of the hospital than placebo at 90 days. But when we look at the statistically positive result in terms of survival and also comparing that with the pre-planned secondary Bayesian analyses, we could say that there was a high probability of benefit and a very low probability of harm. Now, I have a hard time believing that haloperidol is saving lives, but I think we can take from this that it's quite clear that haloperidol is rather benign overall. So again, kind of an interesting and curious finding there. All right, final study, delirium, neurofilament light chain, and progressive cognitive impairment. This is from a Norwegian population-based cohort, which has kind of almost I'll say an unintuitive or non-intuitive finding here. So this is called the CASCADE cohort, or Capturing Acute and Social Care and Dependent Elders cohort. They have here as their hypotheses that delirium will be independently associated with worse cognitive outcomes. I think that's fairly intuitive. But then there's the separate one. They did a mediation analysis that both delirium and increased neurofilament light, or NFL, I'm just going to say NFL in the future, during acute illness will mediate worse cognition at follow-up. And I'll describe what NFL is on one of the coming slides. So this was a 2-year longitudinal cohort study of older adults in Sandefjord municipality in Norway, which I did not know where it was and still technically don't, except that I put an arrow on the map if you cared to see geographically where it is. These older adults were receiving domiciliary care services, so people coming to the home at least once a week. You can see here the exclusion criteria. Lewy body dementia, certainly understandable given the cognitive fluctuations in that condition. Although notably, they excluded psychiatric illness except dementia, which on the one hand kind of is a frustration, but at the same time, I think they really wanted to have as kind of as clean a sample without the possibility of confounding or challenges with diagnostic purposes here. So they use what was called the SQUID, or single question in delirium assessment. So each week, one of the staff who was giving domiciliary services, they were asked the question, do you think this patient has been more confused lately? And if it was positive, then research personnel would conduct a daily delirium assessment, including either at their home or if they were admitted to the hospital, in hospital, throughout the duration of the delirium episode. So a lot of coordination going into this, and really impressively so. The delirium assessments include months of the year backward, reverse digit span, vigilance A, abbreviated mental test, which are these 4 items, the Richmond Agitation Sedation Scale score, and also the OSLA, which is another test of arousal. And ultimately, a delirium diagnosis was made according to the DSM-5 criteria. Every 6 months, beginning at kind of at the start of the study, at the end, so kind of bookending it, and then each of the 6-month periods in between in this 2 years, they did a MoCA, the Cornell Scale for Depression and Dementia. They consulted with caregivers for a neuropsychiatric inventory and the IQ code. They made clinical diagnoses of dementia where appropriate, and they also took blood samples to evaluate for NFL. What is NFL? I've mentioned it a few times. So neurofilaments in the axons of neurons, there are a couple different subunits, and NFL, so the light chain, is the most abundant and most soluble subunit of this neurofilament chain. And as a result, it ends up being a good kind of indirect measure or proxy of axonal, or kind of broadly neuronal damage. So this is an overview of kind of the flow of the study, again, kind of starting at 210 participants. There were individuals who died at each of those in between those intervals, and then ultimately ending up with 141 participants here at the end of the study. Looking at table 1, you see that about half of the subjects had dementia. So does perhaps speak to the population to which this would be most generalizable. In general, those who had dementia had a higher rate of incident delirium, 54% versus 30% in those who did not have dementia at baseline. Average age, 85 at baseline. About 72% were living at home. Average years of education, about 10. The MoCA at enrollment on average was 18, so really on the cusp between MCI and dementia, if you take an overall average. And overall, this is a relatively frail, I should say, sample. So if you take moderate and severe frailty, about 3/4 of the sample with frailty according to the frailty index. And here are our results. So they enrolled 210 of the first 271 older adults screened. So really good recruitment. They conducted more than 2,000 delirium assessments. More than half of those were during acute illness. The cumulative delirium incidence over the course of these 2 years was 42%. Of those who died, 81% had delirium at least once. Overall, those who had delirium had a slight downward trajectory of cognition. But the following 2 images are really where I'll kind of the final outcome that I think is really interesting here. If you had a 30 MoCA to start with and had delirium, you had a greater decline over those 2 years than if you started at 20 or you started at 10. It's a fascinating thing to see that those who started out highest perhaps had the most to lose and had the greatest decline. And specifically looking at NFL, so again, neurofilament light, and then you kind of break this up, those who did not have delirium versus those who had delirium. If you had a better MoCA score at baseline and you didn't develop delirium, your NFL was lower, less neuronal damage. But if you had a higher MoCA at baseline and developed delirium, you had an even greater NFL at follow-up, suggesting that, again, there's greater neuronal damage among those individuals, perhaps explaining to some extent why if you started out higher, you had a greater decline. So what are the strengths and limitations? This is excellent ecological validity. rigorous delirium assessments across levels of care, and also a very high retention rate with few missing data. Some limitations. It's an observational study using an indirect measure of neuronal injury. About half of the sample at baseline had dementia, so that speaks to its generalizability. And then they did not incorporate delirium causes into their analyses. And so I like the way that they kind of concluded this. So I'm just quoting the authors. In people aged 65 years or older who were living at home, we found delirium to precipitate a decline in cognition and an increase in NFL. Again, I think understandable, but the interesting and perhaps non-intuitive part is most evidently in people with better cognitive function at the previous 6-month assessment. So again, I find that really noteworthy. Final slide that I'm going to mention is a very quick shameless plug. The American Delirium Society, the meeting is going to be coming up in June. We're accepting sessions through Monday, but we are also accepting abstracts through January. I'd love to see greater integration between the American Delirium Society and the Academy of CL Psychiatry. So with that, I'm done and I can take a couple of questions.
We'll have time for just a few questions. So let me start with the most striking. Haldol reduced mortality 7%. That's quite something. Do you believe it? And why did it have that effect? And to summarize, one audience member, did it just improve ability to provide medical care in the ICU?
That's a really interesting thing, right? So again, so one of the things they've not assessed here, although they kind of broadly put hyperactive, hypoactive, and we have these proxy values of rescue medications and off-label haloperidol, we're not capturing kind of some of the nuances of the neuropsychiatric disturbances of delirium. And exactly as this question here asks by Paulo, maybe it does. Maybe it has an effect that we're just not picking up in terms of providing better engagement with care. Perhaps it's helping with sleep to some extent. If specifically the doses toward the evening. I find it really intriguing that there are 3 studies, 2 of which are kind of secondary analyses or retrospective analyses, and now this prospective analysis, all of which suggest haloperidol saves lives. At the very least, it's not hurting people. And I think that's something that should give us a greater sense of kind of comfort, or kind of as we're considering haloperidol in recommending it for individuals with delirium.
The research has come full cycle that we thought haloperidol didn't help, and then it seems like maybe it actually did. Let me ask about relay another question about the long-term outcome study. We tell patients that delirium is reversible, but these are a very significant prognostic factor. Should this affect our practice? Should we be talking to patients about this?
Yeah, no, I absolutely think we should. I mean, I think bringing family members in and really, increasingly we're talking about things like post-intensive care syndrome, or PICS, and kind of post-hospitalization syndromes. I think that the integration of inpatient and outpatient and aftercare services should be much greater. And these kinds of data, again, I mean, my hat is off to Sharon Inouye and her team on this remarkably complex and intensive study to demonstrate this. When people have delirium, it apparent even if the delirium is itself not neurotoxic, it says something about the coming cognitive decline. So I think these are things that should be discussed with people, and also thinking about what kinds of services might be appropriate, that people are on the lookout, that if they do have additional care needs, that these are addressed, and that this data informs overall services that follow the patient in the community.
And the biggest effect is really 24 months out. All right. Well, thank you so much for joining us. Thank you so much, Mark. Maybe we'll get you back to do this again next year. We'll see you all in Austin.
All right. Thanks.